Hi, everybody. We're going to do the nutrition care process in our next lecture series. I'm going to warn you about it before I dive right in. So one of the tricky things about this is there's no chapter that goes along with it. So your only way to understand the nutrition care process is through this lecture. For those of you who have already had it, it's going to be pretty easy, and you probably um, are going to catch on really quick and you're not going to have any issues. If this is your first exposure to it, it's a beast. And I will warn everyone that your last case study, your elderly nutrition case study, you have to use the nutrition care process. So if you don't understand it and you don't know what you're doing, you will not do well on that. And it is a pretty heavily weighted activity. I will also let you know that it will be on the exam, and it'll probably not just be multiple choice. I'm sure these would make great short answer questions where you have to write up parts of the nutrition care process. So do not take this lightly. Pay attention and email me or join the chats to make sure that you understand everything. It's kind of difficult to teach. It's a lot easier if we use examples. So I'm taking some of the things that we learned in adolescent nutrition, and then we're going to use examples from adolescence in how we use the nutrition care process. So a couple of things, you will have to know the rationale for using the nutrition care process, and that's pretty easy. That's just sort of paying attention to that slide where we talk about why this is important. You will certainly have to know the 4 steps. That's also pretty easy. You can memorize them or write them down quickly. There's only 4 of them, so again, that's not terribly difficult. This third objective is more difficult and something that you will have to do independently, and all the notes in the world aren't necessarily going to make you be able to write a PES statement. You have to understand the material in order to do that, so make sure that you feel confident about that. Because case study 2 is obviously a case study, and you're going to have to use the nutrition care process. You're also going to have to really be thinking a lot about cases when you do the final exam, which is cumulative. So again, this lecture and this process is going to come into play a couple of times. So here's, I believe, the first objective. So this is talking about what it is, but more importantly, why we have it. So the definition is a systematic problem-solving method that nutrition professionals use to think critically, make decisions addressing nutrition-related problems, and provide safe, effective, highly qualified nutrition care. So in terms of a definition that's kind of long and wordy, you know what a process is, right? You got to go through steps in order to get to what you need. So we're talking about the steps you do when you are providing nutrition treatment for someone or a group of people. That's what the nutrition care process is, in my own words. Why do we do it? You'll really question this if you don't like it. Like, it's tedious, and I'm not even making you use the real standardized language. But the rationale here that we have listed provide a standardized language for documentation and communication. So hone in on that word standardized, right? We are talking about hundreds of thousands of nutrition professionals around the world trying to solve people's nutrition problems. Do we want everybody to do it their own way, or do we want a standardized process where we're using similar language, where we're going along in the same order? Obviously, that's what we're going for, right? Um, we want our interventions, our recommendations to be evidence-based, right? We don't want people making up their own thing. So that should be standardized as well. So there's room for flexibility, but the more standardized we are, and the more we follow the process that's laid out, the better our patient care will be, because we're not all running amok, willy-nilly, doing what we want, making up our own words, deciding what should be a good intervention or not. there's a process that we can rely on. So here's the 4 steps. You have to know these. I have it listed out, and I also have it shown in a circle, but it's the same information. I think it's intuitive. So the very first thing you do if you're going to help someone with a nutrition problem is assess them. We usually do this by asking a million questions, or maybe we're looking in the electronic medical record. But all the information that would help us understand what the nutrition problem is included in the assessment. So we do that the first time we meet someone, and then if you keep seeing that person over and over and over again, we're going to reassess. But it always starts with an assessment. You can't solve a problem if you don't understand it. So once we have gathered that data and we've assessed, step number 2 is a diagnosis, specifically a nutrition diagnosis. So we have our assessment data. Let's really use critical thinking and figure out what the most important nutrition problems are, the diagnoses, because that's how we're going to intervene, right? If we know what the diagnosis or problem is, then we can design an intervention around that. How do nutrition professionals intervene? We often prescribe special types of dietary changes. You have a risk for heart disease, so I'm going to put you on the Mediterranean diet. You have hypertension, so I'm going to put you on the DASH diet. You have low iron or iron deficiency, so I am going to recommend an iron supplement. That's what we do. In terms of monitoring and evaluation, you wouldn't be very good at your job if you didn't monitor and evaluate to see if your intervention worked. So if your adolescent has iron deficiency and you know that because their hemoglobin was low on a blood test, you're probably going to monitor and evaluate their hemoglobin and make sure that it actually goes up. You might be monitoring and evaluate their compliance with their supplement use, or maybe their intake of iron, or whatever it is that you laid out in your intervention. But here we are with our process, right? It goes round and round and round in the circle because it's a fluid, sort of ever-changing, evolving thing when we're working with people. Sometimes the problem's very easy and we solve it through one cycle. Most people have more complex problems and we have all kinds of diagnoses that we're working towards. Sometimes they resolve and you're done, and sometimes they keep going and going and going. But we go through the same process every single time there's an encounter. If you're curious why the A, D, I, M, and E are highlighted in red, is because when we write all of this out, when we write our note describing the interaction with the patient, we call it a ADIME note, or ADIME note. And that is because we're getting the letters from this. So an ADIME note means assessment, diagnosis, intervention, monitoring, and evaluation. So you will have to write an ADIME note for your case study too. Just a little tip. I would like you to write your ADIME note by yourself, but you can Google ADIME notes and they would be hundreds of examples online so you can see what people do and get more comfortable with the language and the formatting. You probably know how to use Google. Haha. All right, let's be a little more detailed about step 1, the nutrition assessment. So the official definition, here's that word again, systematic process of obtaining, verifying, interpreting data in order to make decisions about the nature and cause of the nutrition-related problems. So getting information. Maybe you're asking the patient, maybe it was already somewhere from a referral or the medical record. Maybe, you got a lab value, but you have to interpret it and know if it's high or low, but that's all part of your assessment. It's ongoing and dynamic because you have to do it every single time, right? Because things change. Hopefully the patient gets better. So when you reassess, the problem is improving, and then maybe you get to change your approach a little bit because of that. Hopefully you remember what I mean by the ABCDEs of nutrition assessment. If you've forgotten and you're mad at me for giving you all these crazy acronyms, let me remind you now. A is all the anthropometric data like height and weight and percent body fat or percentiles on a growth chart. B is biochemical data like blood lipid levels, blood glucose, fasting blood glucose, hemoglobin, anything you can sort of measure with a lab test. C is clinical data. This could be another type of diagnosis, like a medical diagnosis, like this person has type 2 diabetes, um, this person has obesity, this person is Tanner stage 3 if we're talking about adolescents. D is easy. D is for diet. So whatever assessment data you have about their eating and drinking habits. E is very broad. So E stands for environment, which includes so many things that might be related to nutrition, like one's ability to purchase food, so their economic situation. Maybe for adolescents, we're talking about if they eat at restaurants or if they eat at home, if they get school lunch, if they have the ability to be physically active, who buys the food in the house, all of those things that go into someone's overall nutritional status. This is a part, if you're not used to it, you'll hate the most. So once you've gathered all that assessment data, which I think is fairly intuitive, you have to make a diagnosis, and you're all familiar with medical diagnosis. So you know what it means when someone has heart disease or type 2 diabetes or even obesity. We have to set our diagnosis apart because this is what nutrition professionals do, not medical doctors. So when we do a diagnosis, we're focusing on nutrition diagnosis where nutrition-related activities is going to be the intervention, right? We're not going to prescribe Lipitor or insulin. We're actually not qualified. It's not within our scope of practice to prescribe drugs. So we focus on interventions that we're trained in, which is often counseling and education. We can, so part of the diagnosis again is focusing on what nutrition professionals' role is in care. And again, often we're really talking about food, right? Food is medicine, and we are using a lot of food-related things in order to treat nutritional problems. Makes sense, should make sense. So that's all well and good, but the way you word the nutrition diagnosis is usually what drives students crazy. So the nutrition diagnosis, the wording of it is something that we call a PES statement. So when I ask you, what's the nutrition diagnosis for this patient, or write a nutrition diagnosis, what I'm telling you to do is write a PES statement. You don't just get to write one word, you have to write an entire statement. So P stands for problem, E stands for etiology, and S stands for signs and symptoms. So the problem is a diagnostic label. This will sound usually the most like a medical diagnosis. And in fact, people often use a medical diagnosis as the P in the PES. We also sometimes talk about problems relative to lab values and food, like excessive carbohydrate intake or inadequate iron intake or inappropriate meal pattern. So that's how we start the PES statement. We are then going to talk about the etiology, and if you don't know what etiology means, it means what causes the problem. So most people will stop at the problem, right? We go on to describe what caused the problem. And we end our PES statement with the S, which is signs and symptoms. And here, again, we haven't stopped like most people. Now that we know what caused it, we're going to do the signs and systems. We're going to provide sort of the evidence that we gathered when we did our assessment that shows that this person really has this problem. What are the signs and symptoms that back it up? So some other parts of a PES statement, and I do want you to do some of the language. So everything highlighted in here, I want to see every time you write a PES statement. So when you talk about the problem, use your own words. But after you're done talking about the problem, you have to write due to. So you have to tell me now what caused the problem. What is the etiology? And you can do that part in your own words. After you finish that, you have to write as evidenced by. And then using your own words, you describe the signs and symptoms. So when you take higher level classes, for most of you that would probably mean medical nutrition therapy, there's actually standardized language for all of the parts of the PES. We're only requiring you in this class to do it in the same order, but you have to write due to and as evidenced by. And I will take off points if you don't do that. So here's some examples, and I'll give you lots, and again, you can Google this and find all kinds of them online. So an adolescent has excessive weight loss. That's the main problem. The etiology or cause is due to inadequate energy intake, and are signs and symptoms as evidenced by drop in BMI percentile from the 20th to the 15th. So where did this information come from? This is the second step. It came from the first step, which was the assessment. And as we're now in the second step, the diagnosis, we have to already be thinking about the next step, the intervention. So when we're planning an intervention, which part of the PES should you focus on? So think about this in different words. You're going to help someone. You're going to solve their nutrition problem. What's the best way to solve a problem? Well, for most people, you solve a problem by addressing the cause of the problem. And the part of the PES that is the cause is the etiology. So inadequate energy intake is what we're going to hone in on when we think about how we're going to intervene. Now, a little bit more about PES statements. Again, these tend to be the hardest for students to write. Make sure that you're really looking at all the nutrition assessment data very carefully. And you do have to think critically because sometimes there's a ton of problems and you want to hone in on the most important. So think about all of them sort of singularly. Sometimes students write these like huge PES statements, right? And like if they do something like inadequate energy intake, and then for the etiology, they list every single thing. You really kind of want to make them a little bit simpler than that. It's going to be easy to stay organized. And you also want to focus on um, problems that are solved by nutrition, right? Sometimes you can't. Sometimes someone's problem really needs to be solved by a psychologist or an exercise specialist or a physical therapist, right? So in that case, you know, your intervention is actually going to be a referral. But for our case studies, we really want to focus on nutrition interventions. So explore the etiology or cause. Again, make sure that it's nutrition related, and make sure you describe the signs and symptoms. So after you write your PES statement, step back. Did your assessment lead to the diagnosis? Sometimes people start talking about problems in their PES statement, and it's the first time I've ever heard of them. You know, they summarized the assessment data and they talked all about diet, and now all of a sudden I'm hearing about food access. But There was no information about that in the assessment. So make sure it all lines up. Look at the etiology, right? This is where you're going to make your intervention. But if the etiology doesn't have anything to do with nutrition, it's not a good etiology. And then now we're going to start thinking about um, monitoring and evaluation as well. So your signs and symptoms, the last part of your PES, those are the things that we usually can measure. So if you're going to have ideal and measurable goals that can be monitored and evaluate, those will come right from the signs and symptoms from your PES. So here's that example. We're just going to think about that. The adolescent had excessive weight loss due to inadequate energy intake as evidenced by a drop in BMI percentile. So let's just assume the assessment data was all there. Can you address the etiology with nutrition? Inadequate energy intake, right? Well, energy is calories. Can a nutritionist figure out the appropriate number of calories? Of course we can. So that is a good etiology. Signs and symptoms. Can this become the basis for setting ideal and measurable goals? So can we monitor and evaluate someone's growth chart? I'd hope so, right? I'd be really embarrassed if you couldn't. So that is a good sign and symptom. So our PES statement is good. Okay, so here's an example of, sorry, an intervention. Looks like someone's using food models to teach someone about portion control. Very common intervention you might do in the nutrition world. So it's a purposely planned action, like what? Nutrition education, designed around your nutrition diagnoses. We want to complete or create a realistic plan with a good probability of working. That's harder to do with a case study because that is really client driven, right? You decide that you want someone to only eat fruits and vegetables as snacks. Well, in the real world, you'd have to be working with that person and make sure that they were willing to do that, that they wanted to do that, that that seemed like a good plan. It should be client driven. Because this is a case study, you can't really ask those types of questions. Um, so we're just sort of trying to do the best we can. The last step is monitoring and evaluating. This is where we determine the degree to which progress is being made and whether or not the client's goals and desired outcomes of nutrition care are being met. In other words, have you done your job? Progress should be monitored, it should be measured, and it should be evaluated on a planned schedule. So what data are you going to keep track of? How are you going to measure that data? Are you going to use a growth chart? Are you going to take someone's body weight? Are you going to have lab works redone? And then evaluate it on a planned schedule should mean, like, how often should you check in with this person? If it's serious and possibly life-threatening, like someone who has malnutrition or is dehydrated, you should probably see them every day. If it's someone who wants to lose a couple of pounds, not as frequently, maybe every other week or something like that. Then you got to write your ADIME note. Again, it falls nicely into the nutrition care process. So the first thing you'll write out is your assessment data, then you'll do your PES statements and your diagnosis, then you'll document your interventions and what you want to happen. And then for the first, you'll plan what you'll monitor and evaluate. And then as you move along with a patient or client, then you'll actually have monitoring and evaluation data to include in this part of your note. So I'm going to give you two examples, just mostly so you have some ideas of how the PES statements would look like. This first example is actually a real patient of mine from years ago, so I don't currently work with adolescents, but I remember this young man. His name isn't really Bob, of course, but I'm protecting his identity. So when I saw Bob many years ago, he was a 15-year-old male in high school. His mom was very concerned with his eating and exercise habits. She says he had gained 15 pounds between freshman and sophomore year and spent his free time playing video games. She thought he seemed depressed, but he won't talk about it. She found candy and chip wrappers in his bedroom, and he kind of played dumb about the whole thing. He didn't know how they got there, even though it was pretty obvious that he was purchasing some junk food and eating it in secret. So, in terms of the assessment, oh, in terms of the assessment, um, I mostly worked with Bob by himself. He was having some trust issues with his mother, mostly because his mom had recently gotten remarried and he didn't like his new stepdad. He barely spoke. He was very awkward. He was overweight. He had bad acne. He did not trust me. He did not want to be there. Um, it was not the most comfortable counseling sessions I have ever had, but I did eventually make some progress with Bob. So, what's the first thing you do? You look at his anthropometric data, and he's 15, right? So we're still using growth charts, and hopefully you could get some type of history. Now, especially for adolescents, we can't go into this much detail, but always keep in mind that, 15 pounds may or may not be significant because he's an adolescent and he might have had his growth spurt in there. So you'd really have to get a pretty good understanding of where he was in puberty and looking very closely at the growth charts and his family history to know how alarming that 15 pounds was. Biochemical data, just to make the case study simple, I'm going to tell you that it was all normal. Some of the things that you might have been interested in when you see weight gain, if that's the primary nutrition concern, you can have high lipids and high blood glucose and high blood pressure in young people. You can have non-alcoholic fatty liver disease, so checking his liver enzymes. Um, he can have nutrient deficiencies, but we're going to pretend that Bob was perfectly fine in his lab work up because he has youth on his side. Clinical data, I'm going to tell you, he did not have any medical diagnoses. He was in Tanner stage 3 in terms of his puberty development. This would kind of give you a clue that he could be in a growth spurt. Again, you'd have to kind of think about that very carefully in determining whether you cared about that 15 pounds or not. We're going to pretend that we do care, that his growth charts did show that that was an excessive weight gain, that he was going up in the BMI percentile category, so his weight was growing more than his height. For diet, you usually on the first visit do a 24-hour recall. So you'd get detailed information about what he had eaten in the previous 24 hours with serving sizes to be really accurate. And then you'd probe even more for other types of eating habits, like what he does on the weekend and how often he eats out. You might want to ask about alcohol. The whole food hoarding, you might start to think about, oh my gosh, is this kid binge eating? I personally didn't go there quickly with Bob because he already didn't like me. And he did eventually admit that he was, buying that candy and stuff. But there was so much to work on with him that you kind of have to prioritize some of it. In the environment, I already alluded to some of the important environmental factors. For a teenager, right, what's the school environment like? What's the social environment like? What's the home environment like? Where's he getting his food from? Even if you started to tackle the candy and chip wrappers, like how does he get money? Where is he shopping? Why would he feel like he needed to hide it? Um, and again, for this particular patient, I did almost all of my sessions with him by himself for the trust factor. Okay. So I'm just giving you a little bit more detail about the case. Um, we had talked about, are we concerned about his weight? Well, honestly, if this was really his growth chart, I just copied and pasted, so this really wasn't his growth chart. But if it was, he's consistently at the 95th percentile for BMI for age. So he's obese. We're seeing him at age 15, so let's pretend that this is here, maybe up here. Um, it's not that he wasn't obese and now became obese. He's always been obese. He's trending that way. So the 15 pounds was probably part of where his growth and development would have taken them. He's staying consistent on the growth chart, but it's still probably not healthy, right? We don't want someone to be in the 95th percentile for BMI. We want them to be um, below the 85th. Of course, you'd have to rule out if he was muscular or something like that, but in this case, we're pretty confident that Bob's weight is too high. Here's his dietary information. I didn't put a ton of detail just because you're looking at it on PowerPoint slides, but I gave you enough so you can start to find problems. So he's skipping breakfast. There's a problem. We know that he eats school lunch and that it's 2 slices of pizza and milk. Um, not the greatest, but at least he's having lunch, I guess. After school, we didn't get a lot of detail, but we can see that he's having quite a bit of snacks, and none of them look very healthy, high sugar, high salt. Dinner, because Bob was not the chattiest guy on earth. Sounds like he has kind of like a standard American dinner. So I wrote 3 example PES statements based on this case. I put he has excessive weight gain due to excessive energy intake as evidenced by his 15-pound weight gain. I put he has an unhealthy eating pattern due to skipping breakfast and snacking after school as evidenced by patient reported skipping breakfast and eating large after school snacks. And lastly, I did pick a kind of non-nutrition one, but I do have some scope of practice in at least encouraging and setting goals for physical activity. So for him, I put patient has low physical activity due to excessive screen time as evidenced by patient report. So we have our second step done. We've got our diagnoses. Now we're going to intervene. We're going to document specific interventions, so ideal treatment goals, start to think about what we hope to find and what we hope to see. And when we think about our interventions, we're mostly focusing in on the etiology. So that's always the first place that I look. So here we go, right? Our first one has to do with weight gain and our etiology, what's causing it in this PES statement is excessive energy intake. So we're going to design an intervention around energy intake, and there's a million ways you could do that, right? We're focused on energy, so how many calories do we think he needs? Maybe we could calculate that out and think about a calorie intake appropriate for weight loss. And write out a meal plan for him. And maybe that's our intervention. Or maybe, he's not a kid that's going to count calories or care about calories, which is probably true of most adolescents. So we're going to focus on energy density. We're going to find the foods that he's eating that are really contributing to his calorie intake and work with him to make substitutions for lower calorie foods. And make goals around that. Let's see. So this one has to do with skipping breakfast and snacking after school. So here our intervention would again probably be sort of behavioral, and we probably work really carefully with Bob to think about breakfast that would be realistic and convenient for him, and then think about snacks. So he likes to snack. I think most kids do when they get home from school. But maybe that there's some snacks that he can have that aren't so high in calories or so highly processed. And the last one, um, we have excessive screen time. So for him, that's in the form of video games. What are we going to do about that? Are we going to try and work with him and figure out a sort of a reasonable rule about screen time? Are we going to work with him and figure out activities he could do um, that would replace some of his screen time? Are we going to find screen time that makes him be more physically active? Like some of the more, um, oh, what am I thinking of? The video games where you dance or move at least a little bit. This is where it would have to be client driven. For the case study, you just have to do the best that you can. And we're almost done with Bob. We're going to monitor and evaluate him. So what would be a good plan for monitoring evaluation? Now we're going to look at the signs and symptoms. So what are we going to monitor and how are we going to know that this is working? Um, so for this, we focus on the signs and symptoms. So for the first one, we know that he gained 15 pounds. So what are we going to monitor? Well, we're going to monitor his weight. Um, and maybe our goal is simply to not gain more weight, right? Maybe he's still getting taller. We have some reason to believe his height's going to increase. And so we just want the weight gain to stop. Maybe we do want some weight loss. That would be something you'd have to determine. Oops, I forgot to be more specific. So for this one, we had focused in on eating patterns. So to show that he has a healthier eating pattern, we'd maybe want to ask him to keep a food diary or some type of checklist, or maybe Bob is more of a technology guy and he wants to do MyFitnessPal, or maybe he just wants to email you every day and tell you how he's doing. I'm guessing the goal around this one would be to have breakfast every day. So that's what we'd monitor and we'd evaluate if he was able to do that every day like we had agreed upon. Um, and the last one, um, using most of his free time for video games. So depending on how kind of we worded the intervention, hopefully we had some goals around screen time or some goals around physical activity. Maybe we wanted to go for a walk every day, but we'd have to decide what exactly we were going to monitor and what the goal is. Maybe it's 2 hours or less of screen time. Maybe again, it's a 30-minute walk 3 days a week. Um, Whatever it is, if we'd have to figure out, you know, what he's going to do so the next time you see him, you can evaluate if he met your goals. All right, I'm gonna do one more quick example and then we'll be done. So now, this is no longer adolescent. I picked an adult. So 48-year-old female, BMI 29, strong family history of type 2 diabetes. She had a high fasting blood glucose. So we can see she's having 2,000 calories a day. Her recall shows coffee with cream and sugar for breakfast, large Cobb salad and roll from the work cafeteria, more coffee, large dinner with wine, eats out 3 to 4 nights a week, mostly like pub style food. She's busy, she's stressed, her family stresses her out, she has no time for exercise. Here we've got some biochemical data. That's what her fasting blood glucose was. So we know that it's on the high side. So she's trending towards diabetes. Her hemoglobin A1C is normal. That would indicate that she doesn't have full-blown diabetes yet. She does not like taking pills. So maybe she's one that's willing to do some lifestyle modifications to help prevent diabetes. So I gave you 3 PES statements, and while we go over them, I just want to also be evaluating them. So especially when we think about the problems, is this all from that assessment data that was on the previous slide? Is the etiology something that can be fixed by nutrition, and do our signs and symptoms, can we use those to something that can be monitoring? So I picked an unhealthy weight due to excessive energy intake as evidenced by patient report of 2,000 calories per, oh geez. Huh, I did two signs and symptoms. Sorry, I must have changed my mind in the middle. So this is a bad PE statement. This was not correctly worded, and if I was grading my own work, I would take points off. But let's pick out the good parts. So unhealthy weight, is that true? Did the assessment highlight that? Yes, it did, because we know that her BMI is 29, and we know that that puts her in the overweight category. Um, so what caused the unhealthy weight? We picked out excessive energy intake. We know that that is true because we know that she's eating 2,000 calories a day, which I'm sure if we calculated it out would be more than what she needs. So let's focus on these two. They're better written, I hope. So increased risk of type 2 diabetes, that's her problem. We know that that's true. We could tell from the note due to high intake of processed carbohydrates. So this is a food-related thing. This is certainly easy to address by nutrition. So that's a good etiology. As evidenced by fasting glucose of 118. This is a hard concrete number. We can monitor it, so we can take her labs again. Hopefully our intervention will bring this down. We have a specific goal, right? We know that we want to get this number under 100, so that's a great sign and symptom. So this last one, physical inactivity, that's the problem due to stressors and time limitations. That's not the best etiology, right? Because those aren't really necessarily nutrition interventions, uh, but we could make behavioral goals around them, or we could make referrals around them. So sometimes, it is appropriate to do these. You would, for me, when you write your PES statements, you have to justify them. So you would just want to describe why you picked that. And our evidence is patient report of no physical activity. So obviously, we're going to monitor this. Maybe we're going to have her keep like a exercise journal or something like that. So this is an example of a PES statement that would be fine. Sometimes they're not perfect, but sometimes you kind of like run out of things to write about, or you think that physical inactivity is really an important part, and for risk of diabetes, it is, that you feel compelled to make a PES statement about it. I found that in this class, we have a lot of students who are exercise science majors, and they like to do physical activity interventions and PS statements, and that is perfectly fine. All right, so now we're going to intervene, and again, we're going to focus on the etiology. So what do you do in intervention for excessive energy intake? Again, we could put her on a new calorie goal, or we could pick out some energy dense foods and replace them with energy dense foods, less energy dense foods. Maybe we could go after liquid calories. Maybe we could go after eating out. This would be client driven, or in the case study, just something you think would be appropriate. Maybe you want to write out a meal plan or something like that. So here's another one. We're going to focus our intervention around processed carbohydrates. So for this one, our intervention might be to replace processed carbohydrates with whole grains. Or maybe, actually that's probably about the only thing we can go do. That's actually a good thing that it's very specific. Here we had that kind of questionable one where our etiology is stress and time. Again, this isn't totally nutrition related, but we do have some skills in like behavior modification. So maybe our intervention is counseling, and maybe we are going to have her start meditating. Or maybe we agree that she is going to go for a walk at her lunchtime and sort of make time for physical activity as part of our intervention. Maybe because it's a case study and you can't really figure out for sure what's realistic because she's not a real person, but maybe you just want to use the physical activity recommendations for adults, right? 150 minutes a week or something like that. And then we're going to monitor and evaluate. So this one's easy. We're going to keep track of her BMI. Maybe we're going to have her come in and weigh every 2 weeks. And maybe our ultimate goal is to get her to a BMI of 28 instead of 29. This one we already talked about. Our monitor and evaluation plan is going to focus in on this biochemical data. Our goal is going to be under 100, and you'd have to think about a good timeline for that. Fasting blood glucose is kind of a more immediate, like hemoglobin A1C, you'd have to do it every 3 months, otherwise it wouldn't be very meaningful. But this is probably one that you could recheck in a month and make sure that it's under 100. And then this one, when we say it's no physical activity, this is one where we might want to use MyFitnessPal or a pedometer or an exercise journal or some type of chart. If the goal was to exercise 3 times a week or whatever it is. But hopefully the next time you see her, and again, you'd want to say what that was, 2 weeks or a month, she will be reporting something other than no physical activity. So that's it, guys. Again, if that's new to you, it's a lot to take in, so make sure you are asking questions and um, especially when you're doing that case study. Don't leave that case study for the last minute. Make sure you do it a little bit in advance so you have time to ask questions and I have time to respond.